Good morning, everyone. Welcome to TeleShadowing. We're live on YouTube. As always, feel free to ask questions in the chat box as we go along in the live stream, and your questions will be addressed. So today we're going to actually be kicking off our nephrology month. I just finished my renal block in medical school, so I'm just going to teach you a bit of the high yield facts and things that we learned. So we're going to be starting off with 4 weeks. We're starting off with basic physiology and anatomy of the kidneys so that we're oriented, understanding like the basic functional unit of the kidney called a nephron. So I'm just going to be introducing the topic to you all today and also how to actually become a nephrologist as well. And we'll also learn a physical exam skill related to the kidneys as well. So let's start off with the anatomy. So kidneys, as you may already know, they're two bean-shaped organs located on either side of the spine, just below the rib cage. And they play a vital, crucial, and very critical role in filtering the blood, removing waste products, and balancing fluids and electrolytes in the body. And I'll walk us through their structure now and how they perform these functions. So we'll start by examining the anatomy of a single kidney. The outer layer is known as the renal cortex. It surrounds the inner renal medulla, and inside the medulla we find structures called renal pyramids, which are the functional units where the filtration actually occurs. And blood flows into the kidney through the renal artery. And there's another slide on the blood flow, the renal blood flow. But here, when blood flows into the kidney through the renal artery, it gets filtered and then it exits out through the renal vein. And the filtered waste actually flows down through the renal pelvis right here, and into the ureter, and eventually reaches the bladder. And each part of this anatomy plays a specific role in the kidney's ability to actually filter blood and also produce urine. So remember, the kidneys, see here, the ureters are here. Now, the length of them differentiates based on whether you're a male or female. So that's just like the kind of the basics of how this all is. And I know it seems overwhelming at first because there's a lot of parts related to the kidney. And when we actually dive into actual a little bit more advanced physiology next week, learning about the renin aldosterone system and how it actually relates to blood pressure and how it really works well or sometimes not so well with the circulatory and cardiovascular systems. But just for now, like this is just again a basic sort of understanding of where we are. So now I'll talk to you a little bit more about renal blood flow specifically. So the process of blood filtration starts with renal blood flow, right? So blood enters the kidney through the renal artery, and then it branches into smaller arteries called the segmental, interlobar. So right here. Segmental, interlobar, the arcuate, and the interlobular arteries. These eventually actually lead into tiny capillary networks that surround each nephron. And like I said before, the nephron is the functional unit of the kidney. Now, now let's just like look at this big picture, right? So cells are the basic functional unit of tissues. Tissues make up organs, and organs make up the organ system. Organ systems make up the organism. So just like now you can also think about like what is the functional unit of the brain, right? It's the neuron. What's the functional unit of the neuron? Just like neuron just means brain cell, right? So here you can consider like a kidney cell or functional unit is nephron. It's called a nephron. So just have that vocabulary in the back of your head. It's very important to know. So blood flows through the afferent. Here's afferent, the afferent arteriole into the glomerulus where the filtration actually begins, and then it exits through the efferent arteriole. How I remember this is that E is exit. That's like a mnemonic I remember, a mnemonic. So E for exit, A, and then A just remember it, so that's how it enters. So afferent into the glomerulus, and then the blood exits through the efferent arteriole into the after the efferent arteriole. And so like this is a very precise network, right, of blood vessels, and it's very important for efficiently filtering the blood while reabsorbing the valuable nutrients and fluids. So we want to be able to tell, the body should be able to tell like what are the waste products, what the body needs, what it does not need when we're drinking fluids, and also filtering our blood. So we're going to just watch just the first 2 minutes of this video. We might finish up the rest of the video next week actually, because it'll actually touch base on the more advanced physiology concepts, all the hormones. We're not going to get into that today. But if you're curious, you can actually watch the rest of the video. But remember, this is an osmosis video, so I want to provide credit where credit is due, and we're also going to be going over some of their slides in the next slides. So we'll have a repetition of this because repetition is really how you'll remember.
The kidney's main job is to filter the blood to remove waste, so it shouldn't be surprising that they receive about a quarter of the blood that the heart pumps with each beat. On average, the heart pumps out almost 5 liters of blood every minute, so 1/4 of that, or 1.25 liters, flows into the renal artery every minute. Blood from the renal artery flows into smaller and smaller arteries, eventually reaching the tiniest of arterioles called the afferent arterioles. After the afferent arteriole, blood moves into a tiny capillary bed called the glomerulus. The glomerulus is part of the functional unit of the kidney called the nephron. There's about 1 million nephrons in each kidney, and each of them consists of a renal corpuscle, made up of the glomerulus and the Bowman's capsule surrounding it, and a renal tubule. Interestingly, once the blood leaves the glomerulus, it doesn't enter into venules. Instead, the glomerulus funnels blood into efferent arterioles, which divide into capillaries a second time. These capillaries are called peritubular capillaries because they are arranged around the renal tubule. Now, blood filtration starts in the glomerulus, where a urine precursor called filtrate is formed. The amount of blood filtered into the nephrons by all of the glomeruli each minute is called the glomerular filtration rate, and it's actually just a small fraction of the blood that gets to the kidneys, because the glomerulus doesn't allow red blood cells and proteins to pass through and be excreted into urine. So right from the start, what passes through the glomerulus is mostly plasma, which normally makes up about 55% of blood. What's more, the glomerulus only filters about 20% of that plasma in one go. So when all is said and done, of the around 1.25 liters that the heart pumps out every minute, the glomerular filtration rate is normally approximately 125 milliliters. This filtrate then enters the renal tubule. The renal tubule is made up of a proximal convoluted tubule, the nephron loop, also known as the loop of Henle, which has an ascending and a descending limb, and finally the distal convoluted tubule. As filtrate makes its way through the renal tubule, waste and molecules such as ions and water are exchanged between the tubule and the peritubular capillaries until blood is filtered of any excess. Finally, the peritubular capillaries reunite to form larger and larger venous vessels. The veins follow the path of the arteries, but in reverse, so they keep uniting until they finally form the large renal vein, which exits the kidney and drains into the inferior vena cava. Now, renal blood flow is proportional to the pressure gradient, which is the...
All right, so now we're going to stop here. We'll actually talk about the pressure gradient a little bit more next week. But I hope that sort of gave you a good overview of kind of what I just talked about.
different...
So on the next slide here, so I'll just like kind of summarize and also repeat a little bit about what we just learned, because sometimes it is a bit too fast. So watching it over and over helps me remember it. So like let's zoom into the nephron, right? The kidney's basic functional unit. Again, this is like the 4th or 5th time I'm saying it for a reason. It's very important to remember. So each kidney has about 1 million nephrons, and the nephron begins with the renal corpuscle, right, where the glomerulus and the Bowman's capsule work together to filter the blood. And after filtration, the fluid actually flows through the renal tubule. And here we have an afferent arteriole bringing blood into the glomerulus and an efferent arteriole taking it out. And so as the filtered blood continues, the nephron will selectively reabsorb water, ions, and nutrients while secreting waste products. So here, this is the glomerulus. The blood is filtered through a 3-layer barrier composed of endothelial cells, the basal membrane, and also the podocytes. And this filtration barrier ensures that large molecules like proteins and blood cells, they will remain in the bloodstream while the smaller molecules like water, electrolytes, and waste products like urea or nitrogen, they'll pass through into the nephron. And this is the first step of urine formation, where the body decides what to keep and what to excrete. So I find that very, very cool. Like we have internal filtration abilities in our bodies. It's very underrated. If you're thinking about, I'm forgetting the name, but basically in the video here, I'll show it again. And I'll mute it this time. But basically, I really liked the analogy it made about, yeah, right here. How, when you're trying to remove something or you're like cleaning vegetables and you have it in this little tin thing right here, you're able to remove waste products. I recently was making matcha the other day, and so I would use this to sort of filtrate out like the bigger pieces to remove what I didn't like, just so that I can just kind of crush it and make it a little bit more smoother powder, but only smaller molecules are able to come out. So that's just one example. Like I really love this analogy, like where the kidney really serves as a filter. All right, moving on. Yes, we're over here. So as we continue along the nephron, the renal tubule plays a critical role in reabsorption and also secretion. So the tubule consists of the PCT, or the proximal convoluted tubule, the loop of Henle, and the distal convoluted tubule, and also the collecting duct. In the proximal tubule, most of the water, electrolytes, and nutrients like glucose are reabsorbed back into the blood. The loop of Henle actually descends into the medulla and has this key role in concentrating the urine. So here, the water and ions are reabsorbed to create this, you could say, balanced concentration of urine based on the body's needs. In the distal convoluted tubule, the body actually fine-tunes the level of, like, now, when you're saying ions, we're actually referring to sodium, potassium, and calcium, really based on hormonal signals from aldosterone and the antidiuretic hormone, or ADH. The collecting duct is really the final stage of the nephron where the urine concentration is finalized. And so by the time fluid exits the collecting duct, it's now urine and is ready to move through the renal pelvis, down the ureter, and into the bladder for storage. And the nephron's ability to selectively reabsorb and secrete ensures that we maintain a very stable internal environment, even when like our intake of water and electrolytes varies. Like some days I'll be drinking like my goal water, like 2 liters of water, and other times maybe not so much if I'm forgetting it. So really, this is how our bodies are able to acclimate and adjust to how much water you're drinking or not drinking. If you're familiar, like sometimes if you're dehydrated if your urine is very like bright, dark yellow, and then you're good if it's like a little bit clearer, right? So that's sort of how you're able to tell when your urine becomes more concentrated. That probably means that your body is retaining more water since it probably needs more water. So drink more water. All right, so that was just very basic, nephron, kidneys, where they're located. Now I'm going to talk to you a little bit about physical exam skills when it comes to like a patient. Let's say they're like complaining about lower flank pain, which is lower mid back pain, and you want to try kind of figuring out what's going on. There's a physical exam called the kind of testing for CVA tenderness. CVA stands for the costovertebral angle. And it's basically the angle that's formed between the lower border of the 12th rib and the spine. So remember, we have 12 ribs. And so at the end of it, this is sort of where the kidney tends to be located. We'll watch a couple of videos as well as to how it looks. So this is the angle formed between the lower border of the 12th rib and the spine, right? So this area is located on each side of the back, right? Because we have two kidneys, and it's used in physical exams to assess for any kidney inflammation or also infection. So when we're performing the CVA tenderness test, you would first position the patient right here. So you position the patient, you have the patient sit up comfortably. If the patient is unable to sit, you can perform the test while they lie on their side as well. You would then locate the CVA, the costovertebral angle. You would stand behind the patient to find it, and on one side, and you'd locate the lower edge of the rib cage. Basically, you like kind of palpate it. And where it meets the spine, and that's basically that angle. You would place your hand there, And you'd place basically the palm of one hand firmly over that CVA, and then you'd strike with the other hand like this, basically on both sides. So we'll show you a video how it looks. But with your other hand, you'd make a fist, and then you're using the ulnar or pinky side of the fist, you would strike back like this off the hand that's over the CVA. And this motion should be firm but controlled. And it's typically done once or twice, depending, on the clinician or the patient's pain if there is. And then when you do that, you want to observe for pain. You'd want to watch the patient's response. And if they react with pain or discomfort, this could indicate inflammation of the kidney or pyelonephritis, which is a kidney infection we'll learn about more in the upcoming weeks this month. And you perform this bilaterally. Bilaterally means on both sides because you don't want to ignore it. If you do see it on one side, you want to check the other kidney as well. So this test is often part of like an evaluation for kidney-related issues, specifically if there are symptoms like fever, urinary changes, or also back pain. So we'll watch how it's done, and there are a couple of videos I want to show you so you can get a broad picture how it happens.
Percussion of the kidneys. The kidneys are located in the retroperitoneum and are well protected by both ribs and muscles of the back. The upper pole of the left kidney can be found at the level of the 12th thoracic vertebra. Because of the liver, the right kidney lies around 3 centimeters lower than the left. Careful percussion of the flanks in the lower rib cage area should not elicit pain in a healthy patient. Pain on percussion, however, should raise suspicion for a pathological process such as pyelonephritis or urolithiasis.
Okay, so this is done a little bit differently. The hand wasn't actually placed on the patient, but in these next videos, it's done that way. Let's watch how it's done here.
Okay, so what you want to do is you want to find the last rib posteriorly, and that is the 12th rib. So if you feel in between the ribs, be about right here, and then you're going to find the spine. And underneath the 12th rib and between the spine is that costovertebral angle. And about right here is where your left kidney is located, and over here is where your right kidney is located. So what we're going to do is we're going to take our hand and we're just going to put it over here. We're going to make a fist and we're going to thump our hand, and we're going to ask the patient if they have any pain. Okay, did you have any pain with that?
No.
Nope. Okay, and then we're going to do it to the other side. Do you have any pain?
No.
Okay, and if they had pain, that would indicate a possible kidney infection.
Right, so of course you want to check, so in a healthy patient, if you do it on a healthy patient, they should not feel any pain. That's also important.
Okay, so
now let's watch another video how it's done.
To assess for CVA tenderness, find the angle between the 12th rib and the spinal column. Place your hand in a fist in this area and use your other hand to tap firmly on your fist.
So there are a couple of different ways of doing it. Some people put their thumb, but the way I was taught, at least in my practice of medicine course, we place the hand like this, and then we just tap it like the registered nurse did in the middle video. All right. Now we're actually going to learn about some specific congenital diseases because we talked a little bit about anatomy and physiology. I didn't get too much into embryology. We could, but we can actually go over a little bit of embryology in this as well, kind of understanding like what happens if the kidneys don't develop properly, right? So remember, embryology is basically the study of the embryo as it develops over the 9 months of gestation in the mother's womb. But during that time, a lot of different things can happen at different weeks at various stages. So sometime, I believe around week 7 after the hearts are developed, the kidneys develop. So what happens if they don't develop properly? Sometimes only one kidney forms. That is called unilateral agenesis. Sometimes neither kidney forms, and that can lead to actually the death of the baby in the womb. There can also just be a single kidney that's only able to function, or there could also be like a horseshoe kidney. Basically, the kidneys basically form, but they're connected like a horseshoe. So let's talk about that a little bit more. So horseshoe kidney. Basically, horseshoe kidneys is a congenital condition, meaning that it's present at birth, and it's the most common type of kidney fusion anomaly. It's actually one of the most common types of congenital anomalies as well in patients. And in typical development, basically, the kidneys form separately, right, on either side of the spine, and then they ascend to their position in the upper abdomen during the fetal development. However, in the case of horseshoe kidneys, the two kidneys that are fused together at their lower poles, basically here, the lower poles, um, they fuse together here and they form a shape that's similar to a horseshoe, right? So that's hence the name horseshoe kidney. So pathophysiology wise, like how this actually happens and what actually went wrong, basically during the fetal development, as the kidneys are basically moving up from the pelvis to their final position in the abdomen, the fused kidneys can actually get stuck. They can basically get stuck together under a major blood vessel called the inferior mesenteric artery. We talked about this during our cardiology month on this artery. It's a very major blood vessel. And this artery, it supplies blood to the intestines and lies right in the path where the kidneys basically need to go. And since the fused kidneys can't fully ascend past that point, they'll end up remaining lower in the abdomen than usual. And this location impacts the kidneys in a few ways. First, they're more prone to certain complications because their position isn't optimal for the normal urine drainage. And so, as urine moves from the kidney into the ureter, it has to travel at an angle, basically. And that can lead to urinary stasis, meaning the urine doesn't flow as freely. And the stasis actually increases the risk of hydronephrosis. Hydronephrosis. And basically, hydronephrosis is the swelling of the kidney due to a buildup of urine. And in a normal kidney, the urine basically moves efficiently through the ureter into the bladder. However, in a horseshoe kidney, you might see things like a uretero-pelvic junction obstruction. Basically, it's a point where the kidney meets the ureter and it's blocked, and that causes backup. So, because of this altered positioning and the drainage pattern, people with horseshoe kidney actually have a higher risk of certain conditions like renal stones, because the urinary stasis can actually lead to the formation of kidney stones because the minerals in the urine, they can crystallize and they can then eventually form the solid masses. And stones can block the urinary tract and that can cause pain and also further complications. People with the horseshoe kidney are also at a higher risk of infections because the stasis, or basically the blockage or the stoppage of the flow, that should be, without any blockages. The stasis actually makes it easier for bacteria to grow, and that increases their risk for kidney infections or pyelonephritis. And also, horseshoe kidneys can also predispose patients to renal cancer, which is rare, but it can happen. There's actually a slightly higher risk of kidney cancers in people with horseshoe kidneys. But despite these risks, like many individuals with a horseshoe kidney, they tend to be asymptomatic, meaning they don't experience symptoms. And horseshoe kidney is often found like incidentally, like during imaging for other reasons, like an abdominal CT scan. So you can see here, this is a CT scan. I'll talk a little bit more about where you can actually see the horseshoe kidney. But basically, the horseshoe kidney has also been associated with certain genetic conditions, specifically those involving like chromosomal abnormalities. For example, horseshoe kidneys are actually much more common in patients with Turner syndrome, which is a condition where a female is missing an X chromosome. It's also linked to trisomies, such as trisomy 13, trisomy 18, and trisomy 21. And basically, these are genetic conditions that involve an extra chromosome. And this suggests that there may be like a genetic predisposition to developing this kidney abnormality, because it occurs more frequently in these populations rather than the general population. So in most cases, like I said before, the horseshoe kidney is asymptomatic. It doesn't cause symptoms, and people can often like live their entire lives without realizing that they have this condition because it can be often found incidentally. But when symptoms do occur, it's usually due to one of the complications we discussed, like a urinary tract infection or a kidney stone. And horseshoe kidney is typically diagnosed through imaging, like an ultrasound or CT scan right here. And that can actually reveal the fused structure. Um, and as for treatment, it's generally not necessary unless like the patient is experiencing complications. And when treatment is needed, it's aimed at managing the specific complication rather than like correcting the kidney itself. For example, like if someone has hydronephrosis or swelling of the kidneys, the goal would be like to relieve the urinary obstruction, like the root cause of the hydronephrosis. If there are kidney stones, they can be treated with medications, dietary restrictions or changes, and also procedures like lithotripsy, and that actually uses like sound waves to break the stones into smaller pieces, and that can actually help them pass more easily. So I guess you could say, like in summary, the horseshoe kidney is one congenital condition of several others, where kidneys are basically fused at the lower poles, as you can see here, and that can lead to being in a abnormal position of the abdomen, because you can see here this is the IMA, the inferior mesenteric artery, um, and that can actually lead to a high risk of hydronephrosis, kidney stones, also infections. And even though the anatomy is different, like most people with horseshoe kidneys, they can live normal and healthy lives. And understanding the structure and also potential complications can help you recognize like how these congenital anomalies can affect organ function, also overall health. Now we're going to talk about a congenital solitary kidney, which is another thing. So basically, a congenital solitary kidney means that an individual is born with only one functioning kidney. And this can arise in two ways. So the first way is through an anatomic solitary kidney. Like this person is basically missing one kidney entirely, like you can see on the right side here. It's usually due to renal agenesis. We'll talk about renal agenesis on the next slides. And then there can also just be one functional solitary kidney, like you have two kidneys, but one is non-functional due to conditions like renal aplasia, dysplasia, hypoplasia, maybe it's polycystic, or like if it's a if the kidney has hypoplasia, one of them basically just means that the kidney is underdeveloped or malformed. Remember when we talked about principles of pathology, I think earlier this year, January, February 2024, we talked about hypoplasia meaning smaller, hyperplasia meaning bigger. Um, so while it does sound concerning, like many people still live, like many people with a congenital solitary kidney can still lead healthy and normal lives. And the body has this incredible ability to adapt, and one functioning kidney can often take over the workload of two. Remember, people donate their kidneys all the time, so that proves that, we can live with just one kidney. So how the kidney usually compensates if it does only have one functioning or one kidney, the remaining kidney usually undergoes a process called compensatory hypertrophy. And that means that the kidney enlarges as and its filtering units, or like its nephrons, they increase their capacity to filter blood, because remember, you're kind of compensating if you were supposed to have a partner but you didn't, so you have to kind of work a little bit harder. And that kind of causes, if you're using something much more, it will increase in size. Remember, like if you are I have my kettlebell right here. So if you are, exercising your muscles a little bit more, it will lead to hypertrophy of the muscle. So if you're using it more, you'll lead to hypertrophy, or it enlarges basically. So basically, the single kidney would work harder and it becomes more efficient, and then it can manage the entire body's filtration needs. And this basically allows the single kidney to handle the increased blood flow and filter the waste products that would normally be managed by two kidneys. So, for example, like if the average size of a normal kidney, if there are two in a healthy individual, is about the size of a fist, a hypertrophic kidney, someone with a solitary kidney, might be noticeably larger to accommodate that extra workload. Um, and like a solitary kidney can often function well enough to support the body, but it does come with some risks to keep in mind. So the first risk is hypertension, because the increased workload can actually elevate blood pressure over time. It can actually also lead sometimes to renal insufficiency because with only one kidney, there is no backup if the remaining kidney starts to lose function. So over several years, the kidneys overwork can actually maybe sometimes can lead to gradual wear and tear, and that can actually increase the risk of chronic kidney disease. The osmosis video we just watched briefly touched on GFR, glomerular filtration rate, but it does have to do with that and creatinine levels. We'll talk about that in the next few sessions. Another risk of just having one kidney includes end-stage renal disease as well, and it's rare, but in rare cases, this condition can progress to severe kidney damage if it's not monitored and managed well. So, actually, another associated risk that I can think of right now is like it's called vesico-ureteral reflux, or VUR. And it's basically a condition where urine flows backward from the bladder into the kidney, increasing the likelihood of infections. And this can also cause additional strain on the kidney over time. So, fortunately, like many people with a congenital solitary kidney don't experience symptoms and they can live full and active lives. This can actually be diagnosed incidentally, often during a prenatal ultrasound or as a result of imaging done for other reasons. And regular monitoring of kidney function and blood pressure is important for early detection of any issues. And this is a form of preventive medicine. And maintaining a healthy lifestyle and staying well hydrated, eating a balanced diet, avoiding the overuse of medications that can harm the kidneys, like certain pain relievers or NSAIDs, they're all recommended to do. So in short, like the body can generally thrive with just one kidney, thanks to the remarkable ability of the remaining kidney to compensate through hypertrophy. And this adaptation actually really underlies how resilient our organs can be even when we are born with congenital differences. Now let's talk about another type of agenesis where the kidneys don't form, maybe both kidneys might not form. So renal agenesis is basically a condition where one or both kidneys fail to form during fetal development. This can occur as unilateral agenesis, or URA, aka the absence of both kidneys, or bilateral agenesis, the absence of both kidneys on the right, BRA. This condition actually results from a developmental issue with the ureteric bud, you can see in this image on the right, which is a structure that usually signals the kidney to develop. And so when the ureteric bud fails to form or doesn't properly connect with that kidney tissue, the kidney doesn't develop. And one interesting factoid is that renal agenesis occurs more often in males than in females. So unilateral renal agenesis, we'll start with that since we just talked about the congenital single one kidney. So this single kidney often undergoes, like we said before, compensatory hypertrophy, meaning it enlarges and works harder to handle the workload of both the kidneys. And many people with unilateral renal agenesis can live asymptomatically, because their remaining kidney can usually meet the body's needs. But due to the increased workload, the kidney is often like at a higher risk of long-term damage due to hyperfiltration, which can lead to CKD or chronic kidney disease later in life. So, in the cases where patients do have the unilateral renal agenesis, you just need to monitor kidney function over time and maintain or encourage that patient to maintain a healthy lifestyle to reduce strain on the existing kidney. So routine imaging like ultrasound can detect the condition, right? Like we said before, and then just have follow-up monitoring for patients like that. But on the other hand, the bilateral renal agenesis, it's a much more serious condition. Here, like both kidneys fail to develop, and that has many systemic effects on the developing fetus. Actually, like without kidneys, the fetus actually can't produce urine while it is still in the womb. And that actually leads to something called oligohydramnios. Oligohydramnios basically means it's a condition that's characterized by like very low levels of amniotic fluid. And normally the fetus contributes to the amniotic fluid by basically like sometimes swimming in its own urine, right? And it basically urinates into its own amniotic sac. But with bilateral agenesis, this process can't occur. And amniotic fluid is very important for the fetus to develop its lungs as well. And without it, the fetus often develops lung hypoplasia, pulmonary hypoplasia, which means that the lungs are underdeveloped and too small to support breathing after birth. So the oligohydramnios, like the absence of this sufficient amniotic fluid, would cause the fetus to be more compressed in the womb, right? Because more fluid means there's more room for the fetus to kind of develop and grow as it should. You can just sort of imagine it as like a flower that doesn't have enough space to bloom its petals if it's like stuck in a cup. So that's sort of what you can imagine the baby as well, or the fetus. It's basically becoming compressed in the womb, and that leads to a range of physical abnormalities known as the Potter sequence or also Potter syndrome, which includes a flattened facial profile. As you can see here, the face is getting a little bit flattened. There are low set ears and also limb deformities, like club feet. And sadly, and very unfortunately, bilateral renal agenesis is incompatible with life. And most affected fetuses are either stillborn or they die shortly after birth due to respiratory failure from the underdeveloped lungs. So, Potter sequence is basically a term to describe the set of physical abnormalities that result from severe oligohydramnios. Because without enough amniotic fluid, the fetus can't float in the womb, and this compression leads to specific recognizable features like lung hypoplasia, the flat nose, a recessed chin, low set ears, cloud feet, and also other limb deformities. And it's actually named after Dr. Edith Potter, who first described these features. And it's important to note that Potter sequence can also result from other conditions that lead to oligohydramnios, not just bilateral renal agenesis. There are other ways as well. So, unilateral renal agenesis generally allows for normal life, but it does require sometimes monitoring of the single kidney for potential long-term issues. But bilateral renal agenesis, on the other hand, leads to Potter sequence, and it's not compatible with life because of its important role the kidneys play in the fetal development, especially the lungs. So understanding the renal agenesis really highlights like the importance of each kidney in maintaining the overall health, and also like how important it is for these organs on fetal development in general. So now that we have some understanding of congenital diseases under our belt, I wanted to actually go over a few case studies. So I'll read this out for everyone. A 68-year-old woman comes to the emergency department because of abdominal pain for 3 days. Physical exam shows guarding and tenderness to palpation over the left lower abdomen, and test of the stool for occult blood is positive, and a CT scan of the abdomen is shown. Which of the following mechanisms best explains the patient's imaging findings? A, failed neural crest cell migration, B, absent tissue differentiation, C, abnormal organ rotation, D, incomplete organ fusion, E, abnormal outpouching of the hollow organ, or F, impaired organ ascent. So I guess, all we really need to look at is the CT scan, I would say. So I'll give you all a hint. So I wanted to actually show this to you. So here, there's a overlay, and this question is from Amboss. So huge credit to them for the overlaying and making it easy to understand here what's going on. So let's focus on this patient's imaging finding. Now, what does this kind of remind you of? These two kidneys looking like a specific shape we talked about. It's looking like a horseshoe kidney. So if this is a horseshoe kidney, how did this happen, right? So this is kind of like a two-step problem. You identify this as a horseshoe kidney, right? But you need to also remember how it actually happened. Like, what was the embryologic insult that happened, or what is the pathophysiology behind it? So, it's actually impaired organ ascent, and I'll explain that to you and just remind you all how that happens. So remember, impaired organ ascent basically explains the presence of the horseshoe kidney at the inferior position that's relative to the normal kidneys. Basically, the fused inferior poles of the horseshoe kidneys, they got caught under the inferior mesenteric artery, which impeded the normal ascension of the kidneys to their retroperitoneal locations, which basically means like it should be a bit lower. It's a little bit too high. Actually, no, that just means that this is a little bit lower. This should be a little bit higher. A good correction. Thank you. And since this obstructive migration is generally benign, it doesn't affect kidney function, and it's not normally associated with ischemia or abdominal pain. And so this CT scan finding is most likely incidental. It is not associated with this patient's current complaint. because it did say that there is a cold blood positive, there's abdominal pain. Usually this is asymptomatic, so there's something else going on, and this is called incidental finding. Now let's talk about another question here. A baby is stillborn at 36 weeks and is delivered in a breech position. There is no detectable amniotic fluid, and the placenta shows amnion nodosum. The baby has club feet, a small jaw, and lacks kidneys upon autopsy. Given these findings, which additional condition is most likely to be found? A, an enlarged urinary bladder, B, underdeveloped lungs, C, a congenital heart defect, or D, a neural tube defect, like myelomeningocele. So this, I'll give you a hint. This is talking about Potter sequence, and specifically talking about so clearly it's in the question it's saying that upon autopsy this fetus lacked kidneys. So this is sounding like a bilateral kidney agenesis. So what happens here, remember we talked about the pathophysiology behind Potter sequence, is this lack of amniotic fluid leads to the lack of it leads to pulmonary hypoplasia or underdeveloped lungs. So the correct answer here is B. Because this scenario is presenting with Potter sequence, which is resulting from that severe lack of amniotic fluid, aka oligohydramnios. And normally the amniotic fluid is produced in part by the fetal kidneys. However, in cases like this one where there's bilateral renal agenesis or the absence of both kidneys, the amniotic fluid is drastically reduced. And this absence of fluid actually restricts the fetus's ability to move freely, which leads to physical deformities such as club feet and a micrognathia, which is a small jaw. And the lack of amniotic fluid also affects the development of the fetus's lungs. So pulmonary hypoplasia or underdeveloped lungs is a major consequence of Potter sequence. The amniotic fluid is essential for normal lung development because it allows for expansion and stretching of the lung tissues. And without this fluid, the lungs can't expand properly, which result in poorly developed lung structures that are insufficient for sustaining life, aka incompatible with life. So among the listed choices, the answer is pulmonary hypoplasia or underdeveloped lungs at option B, since it's a hallmark feature of Potter sequence due to the renal agenesis and oligohydramnios. So you can see here how, one small thing that can go wrong, like the kidneys not developing properly, can lead to a stillborn. So now that we've kind of discussed a few case studies, I did want to talk about, like, this is kind of interesting to you, and if you're interested in it throughout this month, we do have other nephrologist sessions done by nephrologists, and we have a course on teleshadowing by nephrologists, or a couple of them during our previous nephrology months in prior years. So I'm just going to talk to you like how to become a nephrologist. So remember, like these kidneys, they play this vital role in filtering blood, regulating fluids, electrolytes, acid-base balances that we haven't talked about yet, and also to removing waste products. And each nephron, it works as a tiny processing unit, ensuring that only the necessary substances are kept, while the ones that we don't want, the unwanted ones, they're excreted as urine. And this filtration process, combined with the kidney's reabsorption and secretion functions, maintains our body's homeostasis. So understanding kidney anatomy and physiology really helps us appreciate how our bodies handle waste and manage these crucial bodily functions. So if you're interested in becoming a nephrologist, here's how you do it. So you start off with a bachelor's degree and you continue on from undergrad into medical school after taking the MCAT and going through all those hoops to get in. And then you do medical school. Now undergrad in some med schools can be 3 years or 4 years, depending where you go. Most places medical school is 4 years, but there are some programs opening up in the United States that are becoming 3 years long. And while any major is acceptable, there are courses, you can really do any major to get into medical school, right? So after college, you will attend medical school, which takes 4 years, and the first 2 years typically focus on the pre-clerkship curriculum, which is like foundational sciences and clinical skills. Then you'll take the STEP exams, the USMLE STEP exams, which stand for the United States Medical Licensing Exams. And then you will go into either an internal medicine residency or a pediatrics residency. So, because you can become either a pediatric nephrologist or a internal medicine or an adult nephrologist. So, I'll talk about an internal medicine residency first. It's 3 years long. You'll enter into this 3 year internal medicine residency that provides training in general internal medicine, where you'll basically care for adult populations with a variety of medical conditions, including kidney diseases. And during residency, you'll basically gain a foundational understanding of the kidneys and their role in overall health and well-being. And many residents, they basically find their interest in nephrology to solidified during their rotations because internal medicine residency, you have like critical care rotations, endocrinology, cardiology, and so forth, because these fields overlap with kidney health. And then during the end of this residency, you'll apply for a nephrology fellowship, which ranges from 2 to 3 years. Most adult nephrology fellowships are 2 years long, but pediatric nephrology fellowships tend to be 3 years long. So after completing your internal medicine residency, you'll enter this 2 year fellowship in nephrology, and during this fellowship, you'll receive the specialized training in kidney care, dialysis, kidney transplantation, and the management of kidney-related diseases. So you'll also learn about like complex cases involving kidney failure, chronic kidney disease, electrolyte disorders, and the management of patients on dialysis or after kidney transplant. So, as an internal medicine doctor, you can still treat patients who have like kidney disease, but you'll be much more involved with their dialysis and kidney transplant post-operative care as a nephrologist. You can also do a lot of research throughout the way. And if you're interested in treating like the children populations, then you'd go through the pediatric nephrology pathway route. So you do a pediatrics residency instead of an internal medicine residency. In pediatrics residency, the same length is 3 years long. And then you would apply for a 3 year pediatric nephrology fellowship where you'll focus on kidney diseases in infants, children, and adolescents, and basically covering conditions that are unique to the pediatric population. Because remember, kids are not just mini adults; they have their own processes. So pediatric nephrologists, they manage issues like congenital kidney abnormalities, like we talked about just now, genetic disorders as well, and other kidney diseases that are specific to children. And after completing your fellowship, you'd also want to complete the board certification and licensure. So really, the exams don't really end because there's 3 step exams to become like a board licensed physician, and then you would do a board in the after internal medicine boards, you do like a nephrology exam. But that validates your expertise and allows you to practice as a nephrologist. And then you can also do like advanced subspecialties like transplant nephrology or interventional nephrology, like dialysis access procedures. They typically require, like, if you want to become like subspecialized, they require maybe like an extra year of fellowship training that allow you to really develop these highly specialized skills. So as a nephrologist, I remember I learned like nephrologists, they basically work in a variety of settings, including hospitals, outpatient clinics, dialysis centers, and also academic and research institutions. They basically nephrologists manage their clinical care with teaching or research as well. And given the rising rates of kidney disease, nephrology is a field that continues to make like a significant impact on patient care. And in summary, so to become an adult nephrologist, you go through 4 years of medical school, plus 3 years of residency, and then 2 years of nephrology fellowship. And then for a pediatric nephrology, if you want to treat kids, you'll complete 3 years of pediatric residency, then a 3 year pediatric nephrology fellowship. And I've talked to a couple of nephrologists, and they always say that nephrology is a very rewarding field that allows you to really manage complex and critically important systems in the body. And they help patients manage very challenging conditions and really improve patients' quality of life, especially through dialysis. So I hope that convinced you if you're interested in nephrology to kind of learn a little bit more, explore shadow in person, kind of visit dialysis centers if you know someone who is going through dialysis, or talk to them about their experiences, because dialysis is a very intensive procedure. Dialysis, we'll talk about a little bit more why it's needed in patients with chronic kidney disease, but sometimes patients are going for up to 5 to 7 hours a day, 3 days or 4 days a week, because basically they're either the patient is waiting for a kidney transplant or they're not able to get one, and then they have to just go on dialysis, which is basically a machine that does the filtration for you. But you have to remember, we have 5 liters of blood in our body, remember our cardiac output. So you want to be able to filter all that blood through a machine, and that takes time, especially because you're taking the blood out of the body and putting it back in once it is filtrated. So we'll talk much more about dialysis later on, but I hope that gave you just a brief interest, I hope, and we'll continue on with our next week's session on physiology and pathology a little bit more. And the link to the TeleShadowing quiz is now live. You'll need a 70% or higher as always to pass and receive certification on teleshadowing.com/certification. We also have a nephrology course open for students who are interested in learning more from the physicians themselves who are nephrologists and went through all that training and went over a couple of case studies as well. So thank you so much everyone for joining, and I hope to see you in next week's session. Take care everyone. Bye-bye.